Good morning. Today, I'll be covering the topic treatment planning in orthodontics. As we all know, planning the treatment is the best possible way of getting a successful outcome for an orthodontic treatment. Basically, in orthodontics, the problems are you can deconstruct it into this picture. It could be either a problem with the maxilla or mandible. It could be an overgrowth of maxilla or an undergrowth of maxilla or an overgrowth of mandible or an undergrowth of mandible or a combination of both of maxilla as well as mandible. So basically you have, if you look at the two white blocks, they are the teeth, maxillary teeth and mandibular teeth. Whereas here you can see that um, the the yellow blocks represents the maxilla and mandible, and you have the craniofacial area here, which is limited to us. Our area of planning is limited to this area, which is the maxilla and mandible and the maxillary teeth and mandibular tooth. So basically you're dealing with either an overgrowth of maxilla or an undergrowth of maxilla, a overgrowth of mandible or an undergrowth of mandible. And the problems in orthodontics can be again simplified into problems in the vertical plane, horizontal plane, and transverse plane. You need to organize these problems. We all know that the problems in the anterior posterior plane, which is otherwise called sagittal plane, includes problems of maxillary and mandibular prognathism, maxillary protrusion, mandibular protrusion, etc. In the transverse plane, we have problems like crossbite, dentally, as well as facial asymmetry when it comes to a skeletal problem. Or whereas in the vertical plane, we have problems like open bite or deep bite, which can either be a skeletal open bite or a dental open bite. So you have to organize, first of all, you should have a good perspective of the three planes. The vertical plane is from top to bottom. Transverse plane is either from right to left or left to right. When you look at a patient, that gives a perspective on the transverse plane. And in the sagittal plane, you will have extraorally, when you look at the patient, you will know whether the patient is having a convex profile or a concave profile. And you will get a rough idea about what is in store when you look intraorally. Then when you look intraorally, you should look at whether the patient is having a spacing problem or a crowding problem. For that, you have the Bolton discrepancy. Then whether the malocclusion is limited to an individual tooth position, whether there are any ectopic eruptions or missing tooth. Then you need to address the pathology. Already in the diagnosis, you might have come across what you mean by orthodontic triage, which is different from what the medical people terminology of what a triage is. Here, we organize the problems as where the pathology needs to be addressed first. So if there are any caries teeth, any other anomalies, or if the periodontal condition is severely compromised, or any tooth is requiring any endodontic intervention, that has to be first addressed before you start the orthodontic treatment. Similarly, medical conditions of the patient, whether the patient is asthmatic, whether the patient is having any juvenile diabetes, juvenile arthritis, all these have to be factored in before you start the treatment. Plan when you plan. Then you have to prioritize that problem list, which every problem related to orthodontics can be classified into mild, moderate, and severe. If you look at malocclusion, we all know that malocclusion is not a disease per se. It is more of a disability where it is highly subjective, where when the patient's what to an orthodontist looks moderate might be mild for the patient. So we are not encountering a medical situation where there is a pharmacological intervention. It is more of a disability, and people's perception, the ideas of aesthetics and beauty has to be factored in. You cannot impose your treatment plan on a patient. So classification may be subjective, especially while we are dealing with aesthetic issues. Pathologies are always considered severe and needs to be addressed before any orthodontic treatment begins. And patient's chief complaint must be included in the problem. So the transformation is from diagnosis, which roughly means what are the patient's problem, and then you tailor make a treatment plan. What structure should I move to correct the problem? And you all know what are the treatment objectives which are given by Jackson, as we commonly know as the Jackson's triad, that is aesthetic harmony, structural balance, and functional efficiency. So whatever plan you make for the patient, which what structures should I move to correct the problem, it should be a tandem with these three common goals of or the three common objectives of every orthodontic treatment. So in general, ideal treatment objectives are same for the patient. That is a balanced soft tissue profile where there's a good aesthetic harmony between the nose, lips, and the chin. Dental and ideal angles class 1 molar relation as well as the canine relationship. Skeletal angles class 1 skeletal relationship as well. You should always ask yourself, do you have the same objective as your patient? So ideally, the skeletal solutions require are needed for skeletal problems and dental solutions for dental problems. So the surgical solutions available for skeletal problem for an adult is surgery, whereas for a growing child, we always have the option of dentofacial orthopedics. For dental, if it is limited to only dental problems, you require only dental solutions. But somewhere in between, as we mentioned earlier, we always have a scenario of an aesthetic issue, and patient may not always agree with your version of ideal. The patient may not want or may not be able to undergo the necessary treatment to reach an ideal outcome. An orthodontist can be an idealist, but he should always factor in what the patient requires or what he chooses according to his or her comfort level. So, as a compromise, there is always an option of camouflage treatment. In the orthodontic perspective, camouflage means you use a orthodontic treatment to mask an orthopedic problem. For example, a patient presents with a 10 millimeter overjet, but we all know that there is a maxillary content involved where there is a sagittal maxillary excess. So you patient is refusing to have surgery for that. If the mandible is in decent position, extracting the upper first premolars is an option. That is called you are camouflaging or masking an orthopedic problem with an orthodontic solution. It is important also to tell the patient that results may not be ideal. So you have three components: the facial, skeletal, and the dental. And we are looking at three planes: the anteroposterior or sagittal plane, transverse plane, and vertical plane. And these are affected by three variables. They are the growth, which we have studied in the relevance of growth, the growth spurts happening, different tissues of the different systems of our body growing at different stages, and paramountly, the cooperation of the patient and the interdisciplinary approach of treating the pathologies first before you plan the treatment. So it is not only necessary that you have the right treatment plan, but you should be able to carry out the mechanics. So what are the treatment options so available? right now. For a growing child, we have growth modification. That is why our department is called Orthodontics and Dentofacial Orthopedics. Dentofacial orthopedics take care of the growing children who requires a growth modification procedure for correcting their skeletal problem in a growing phase. Then you have surgery versus non-surgical. For an adult patient who are seeking orthodontic treatment for an aesthetic issue when they are 30 or 35, we have to plan in conjunction with the oral surgeon a surgical plan for the patient. Then, if it is not a skeletal problem, we don't require a skeletal solution. We only have a dental problem. Then, how will you resolve a protrusion or how will you resolve a crowding? Then you have the option of treating the patient either through non-extraction procedures or extraction procedures. Extraction procedures involve therapeutic extraction of certain teeth, mostly first premolar, sometimes second premolars, for correction of protrusion or crowding. There are other means of non-extraction like space, other methods. And then you think about whether to treat the patient with a fixed appliance or removable appliance. So what are the growth modification procedures available? You should look at the skeletal age of the patient. Many number of skeletal maturity indicators are available, and there are uh, associated analysis to be done to assess the skeletal age of the patient. Then you take up growth modification procedures. In maxilla, you can have, when it is a scenario to inhibit a maxillary growth, you have cervical headgear, high pull headgear, J hook headgear, or a combination headgear. If you want to encourage the growth of maxilla in a class 3 situation, you have protraction face mask or reverse pull headgear. And if you want to increase the transverse dimension, many appliances are available: quad helix, W arch, rapid palatal expander, etc. When you come to mandible, if you want to inhibit the growth of a mandible as well as in class 3 situation, you have chin cup. If you want to encourage the growth of class 2 situation where you want to encourage the growth of mandible, countless number of appliances are available like Herbst appliance, Mara, Twin Block, Frankel 2, etc. are available to bring the mandible forward. So the other options are surgery versus non-surgery. When you plan the treatment, can the patient's malocclusion be corrected by orthodontics alone and still be stable? Is the skeletal discrepancy great enough that the orthodontics alone cannot be used to camouflage the patient's malocclusion? Is the patient a good surgical risk? Is the patient willing to undergo surgery to correct the malocclusion? Patient is education is paramount because the patient should know what he or she is stepping into. Then uh, I have mentioned earlier about therapeutic extraction. There are other methods of gaining space like dislicing the molars. You can procline incise a little bit and gain space, upright the posterior teeth and gain space. You can expand the mandible, maxilla with appliances like Hyrax, Marpe, Sarpe, etc. Usually the therapeutic extractions involve first premolars. Then finally, you should select whether the option of fixed appliance or a removable appliance. Which appliance is used will depend on a number of factors like compliance, severity of the problem, purpose, and the patient demands. So we have other options available in fixed appliance, like for aesthetic needs, you can have ceramic brackets. Then you have aligners as removable appliance, as well as Hawley's appliance and retraction appliances. So advantages of removable appliance are more hygienic. Patient can remove the appliance as and when required. Disadvantage, they only tip the teeth, require cooperation. They can be lost and broken. So in summary, prior to orthodontic treatment, a considerable effort must be spent on collecting an accurate database, Then after collecting the database, you have to analyze the database, arrive at a good diagnosis with the aid of the diagnostic aids like essential diagnostic aids like OPG, then you have cephalogram, etc. Study models, you do the study model analysis, identify the treatment objectives, develop a treatment plan that is acceptable to both the patient and the clinician. And then you decide on the best mechanical approach to accomplish the plan. So a successful orthodontic treatment is the result of teamwork. It involves a constant and good communication between the orthodontist and the family dentist and the patient, patient's parents, as well as orthodontic staff. So it is interdisciplinary and a collective and a collaborative work among the dentist, general dentist, orthodontist, patients for parents and orthodontic staff results in a successful orthodontic treatment outcome. Thank you.